Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Hi, everybody. Welcome to Interdisciplinary Case Miles. I am excited that you're here. We're all excited that you guys are here, back again for another case. How are you guys doing tonight?
Doing good. Sipping some coffee over here.
I'm jealous.
This late coffee consumption, and I'm 2 hours behind you guys. I could never.
I actually meant to make a cup of coffee because I haven't really slept in 4 days. No, not because, I have, but I was at, so we're filming a couple tonight, and I was at running camp, and my fire alarm went off at like 4 a.m. in the cabin. There wasn't really hot water for the shower. Some people got it, but I never got a hot shower. And then also, there was band camp nearby, so they were playing the band near running camp. I can't make this up. I could keep going, but it was also 50 degrees or less at night, and there was no heat in the cabin, and I could only fit one blanket inside of my bag when I flew up there. So I had 3 pairs of pants on. So anyway, I would love a cup of coffee because
I think you need a lot of things.
Before we came out, so I flew home. I jumped in the shower and got a hot shower because I was like, oh, this is the most lovely thing I've had in so long. I washed my hair. Anyway, sorry.
I feel better about my week now.
Do you? I'm really glad to hear that, Sarah. But I don't want anyone to think I didn't love it because I actually loved running camp. It was super fun, but it's just one of those things I like to say, I think it just, builds character.
Just a little rough in it.
Just a little rough in it. Okay, so today we're going to talk about a case that a couple different things that we really, I think that this is missed a lot, actually, which is why we're talking about this. But I'll present it. We have a 32-year-old female runner, and she's also a triathlete. She presents with pain in the left anterior, so anterior is front of the hip, and also the groin. It travels down the leg just to mid-thigh, but not any lower. And she's describing her pain as deep pain. Sometimes it's sharp, but mostly it could be catching or pinching. Things that she has a hard time with are there's pain with sitting, particularly if she's sitting like deep in a chair. So like on the couch, she has a hard time getting up from the couch when she's watching a movie. She has a hard time when she's doing a lot of flexion, so bringing your knee up, crossing her legs. She likes when she's eating or sitting down. She also has a hard time with rotation. So she's if she's standing and she has to quickly turn and look in the other direction, that bothers her as well. Let's see. She's noticed that with her running, her stride length, so she just doesn't feel like she can get a long stride anymore. It feels like it's slowly decreasing, and she can't really figure out why. And she's also noticing that the longer she runs, the worse that it gets. And she's getting a little bit of pinching at the top part of the cycle when her leg is going on her bike. So the very top of the cycle when her knee is totally flexed or bent. Flexion is bending. I have to be careful so everyone knows what we're talking about. So that's basically the case. So she's coming in, she's had all this stuff happening, and she wants to figure out what the heck is going on. And so she's going to see you first, Sarah. And why don't you go ahead and let us know what you're going to ask about and maybe why?
Yeah, so this would be a lot of history here. If I'm seeing her for the first time, we oftentimes start with really basic stuff. So doing some basic physical therapy things to address hip joint essentially. But a couple of things I think about. So of course, we're already kind of introducing this groin pain concept. And so groin pain will classically make you think, oh, is this the hip joint itself? But I also have a lot of folks who will come in and have soft tissue pain. So they're describing it as muscle or tendon. And oftentimes that can fool us and make us think it's just soft tissue and nothing to do with underlying. And so trying to kind of piece out with the physical exam, do we think there's a hip joint component? Because sometimes it's helpful to do some physical therapy, try to calm down all the soft tissue, and then figure out, is this actually the joint that's a problem that we need to address a little bit differently? Sometimes PT can kind of nip it in the bud, and other times we have them come back and they're like, hey, some better, but I'm just not back to normal. So certainly getting some x-rays at our first visit, and if things are just not making progress, we might potentially get an MRI. But if things aren't making progress, I may also start investigating some other avenues. So anytime someone has a hip pain, and especially if it's not improving with kind of the generic physical therapy addressing hip and low back and core, I'll start asking some questions like about their pelvic floor, for example. So asking if they have any urinary symptoms, any bowel symptoms, and those may look like having pain with bowel movements, or incomplete emptying, or urgency for urine or stool, or they feel like it's hard to get the urine flow started, or they have pain with intercourse, for example. So all kinds of different ways that pelvic floor pain can come about. Even having sit bone pain or tailbone coccyx pain. Those are all attachments for some of the pelvic floor muscles. And the way I like to talk about pelvic floor is that it is a part of your core. If you think about your core as a cylinder, the pelvic floor is the bottom of that cylinder. And so it's just like any other muscle that we're dealing with. And oftentimes it can mimic that pain that's happening in the hip joint or these other locations. And so if they're continuing to have pain, sometimes one of the routes that I'll go, if they answer yes to some of these questions, or if they answer no, but we're just not getting better, is getting an evaluation of the pelvic floor physical therapist. And so even just the evaluation and finding out, are some of these muscles really taut? Are they having trouble contracting some of the muscles? We can get a lot of really good information from that standpoint as well. I do want to back up a little bit because I saw Kate itching to give her 2 cents. But when we talk about the cylinder, I love hearing how she describes how she would approach some of that physical therapy and training for the core.
Okay, I just get excited about talking about cases. So I'm over here thinking like, sorry. I think I also wanted to say, one of the things that, if they were coming in with to see me as well, or sometimes they come and see me before they see you, or you know what I mean? It just depends. I would definitely be looking for, is this something like a hip flexor issue, like soft tissue, like you said? So a lot of times people come in with this hip flexor pain, and hip flexor pain or symptoms can be either hiding like a bone stress injury. So I've seen it hiding like a femoral neck bone stress injury, but it could also be hiding, an FAI, so like and it could also be a hip flexor. So there are a lot of different things that you kind of have to think about from that perspective. And then I also would want to, of course, rule out the lumbar spine, like L1, 2, 3-ish, whether facet or discogenic or something like that. So those would all be in my head in terms of like, okay, where is this hip pain actually coming from? And I would do physical tests. You would do the imaging, which is why we need each other, among other reasons, not just for our emotional support that we have for our text message chains. But those are kind of some of the things I would think about. But then coming back to the pelvic floor, anytime someone has hip pain, I feel like we need to consider the pelvic floor. And I think, again, it's happening so much more often now, and people are actually talking about pelvic health therapists and know that the pelvic floor has muscles. That's pretty cool. But I would say that what Sara was describing, the pelvic floor piston, that I get excited about is that we have to think about our breathing. So we have to think about how our diaphragm sits up here, our pelvic floor sits down here. In the front, we think about our abdominal muscles, like our deep abdominal muscles that are supportive. And then in the back, like our deep back muscles that are supportive. And if we think about posture and running in particular, we think about like, okay, is that rib cage stacking over the pelvic floor? How are they holding themselves running? Because if their rib cage is sticking out, then when they take a breath, their diaphragm is dropping, but maybe it's dropping out here. So I guess the video is better out here. So maybe it's dropping down here and it's not really coming down with the pelvic floor, creating that piston stability. So we really need to have kind of that breathing dialed in if there is in fact a pelvic floor issue. And I think a lot of PTs can look at that and look at the posture and look at the thoracic spine and the positioning, the running form, even if they're not a pelvic health therapist, but they definitely still need a pelvic health therapist to do some of that in the internal work. Is that what you were thinking?
Yes, exactly. And so I will oftentimes introduce some of those concepts and give them some resources. And sometimes I tell them, hey, the physical therapist that you're working with, will you mention these things to them and say, hey, can you show me how to do some diaphragmatic breathing? Or do you know how to activate your TA, your transversalis abdominis? So asking if they've actually gone through some of these basics, because sometimes I find that athletes in these scenarios are weightlifting with their physical therapist. And maybe that's fine, but if they came with pain and I'm concerned about a pelvic floor component and we really need to go back to the basics and retrain the biomechanics, we need to go back and figure out how to activate all these really important core muscles. I think one of the most eye-opening moments is when I had a close friend who is very in tune with these types of things. And she said, man, my back always hurt when I did abdominal exercises. And, I just didn't really think anything of it. And then I realized I could do abdominal exercises and not contract my core. And that's always stuck with me, is that there are ways that we can get around things and not use the really important muscles. And the longer we go, or you start getting pain patterns that turn off those muscles, it makes it hard to contract. Folks who are postpartum, man, it's hard to contract some of those muscles when you're trying to get them back to their previously normal state. And so I do think going back to the basics is so, so important. And it's so easy to pass over it because they're boring. And I always tell patients that. I'm like, you need to do the boring exercises. All right, so stick with me, hang with me. We'll get to the fun stuff. But in the meantime, we'll do the boring low impact. We'll do the boring tiny muscle groups, but it's going to pay off. So I try to set those expectations with that as well. I got a little bit deviated with all of this, but I think coming back and exactly like what you said, Kate, there's so many pain patterns that can refer to the groin area. There's so much that can be going on. And so there's a lot of stepwise trying to figure out what's going on. And a lot of things will kind of overlap in the treatment process in terms of working on core is going to help the back and the hip, regardless of where you are. I think one thing that's really helpful too, especially if folks are having any kind of pelvic floor pain or sitting pain, or if they're complaining of proximal hamstring, is evaluating, could this be pelvic floor like obturator internus? And so there's a couple of good mimics that it helps to have a wonderful physical therapist like Kate to send them to and call them up and say, hey, what do you think about this? Could you do a little bit more evaluation and see if one of these things is involved? I also find that educational component is so helpful. So when I've sent patients for a pelvic floor evaluation, even if they see the pelvic floor therapist and don't necessarily go back for continued treatment, just that insight that they develop with their body and understanding how everything is connected, I think makes a really big difference.
Yeah, I think so too. And I think I want to bring something back a little bit further too. So we're talking a lot about the pelvic floor because it's necessary to talk about it. And it's for this particular case, it's part of the issue perhaps. So if somebody is talking, if somebody comes in and they have maybe mentioned that they were leaking with running, so stress urinary incontinence or, coughing and jumping and having some of that, then we would definitely go down that path as well. So it may or may not be, but I always have a pelvic health therapist look if they have kind of this hip pain. But in this case, we are going to assume that there is a pelvic floor component, but it's also something else that is caused by that can cause groin pain and anterior hip pain. And there's a particular diagnosis, and it has two different pieces that I want you to kind of dive into, Sarah, and talk about that it can be. So what FAI is, and maybe talk about a little bit of the difference between like pincer and cam, just so people have an understanding if they, Google it, ChatGPT, or they hear somebody say, what is this? If you could explain that, and then I'd love to go into some of the biomechanics. And I have so much to ask Kelsey too, but we promised we would talk through some of this first.
I was literally going to ask about FAI because I don't understand. So perfect.
Yay.
So hip impingement or femoroacetabular impingement. There's a few different shapes of the hip joint that can cause this particular pattern. So if you imagine the femoral, I always give the femoral head neck junction. So usually you have this really round ball, and then you have the neck that attaches to it. But if you have a little extra bone that builds up between the ball and the neck, then as that femoral head is rotating in the socket, it's going to end up actually abutting the socket a little bit earlier than it otherwise would if it did not have that extra bony buildup on the backside. So we call that a cam lesion, where you have that extra bone that's laid down. And then if the socket is a little bit bigger, so here's normal socket. If the socket is a little bit deeper, so you have this extra pincer deformity, then as that hip rotates again, you're going to have these two areas abut each other a little bit sooner. So kind of the basic idea of it, you get in that deep hip flexion, and it can really be irritating. Now, your labrum, the soft tissue component in your joint that helps give you some stability, happens to sit right between those two components. So if you are already kind of, those areas are abutting each other sooner, they may also be pinching the labrum, putting at risk for having a tear. So hip impingement doesn't necessarily mean there is a tear, but it puts you at higher risk for having a labral tear, which in and of itself can cause symptoms as well. So hip impingement is relatively common, and there's two ways that folks will get it. One is during adolescence. You can have some extra buildup along that growth plate. And so especially like soccer players, runners, so really high impact cutting sports, kicking sports, they're more likely to develop that. And there's also hip impingement degenerative type process too that's happening as part of the osteoarthritis process later in life. So we see a little bit of both of those things. And one thing I always tell people when I see them in like their 30s is if you just started having hip pain, it's quite possible that hip impingement has been there the whole time. So I like to tell people it's just something got off in our training, and oftentimes we can kind of get it back. Now, if there's a new labral tear, it's a little bit different picture, but oftentimes it's just that we overdid it, or someone had a new baby and we've had 2 years of kind of off and on exercise, and then you're kind of getting back to it. So some kind of disruption in that plan can also do that as well. So that's kind of the gist with the hip impingement. Now, that's really talking about the joint itself, but all these other components around the hip joint are along for the ride too. So the glute tendons, the iliopsoas tendon on the front side, your hamstring, your pelvic floor, everything is attached. And so kind of depending on how long you've been dealing with it and how your body is compensating, that can kind of pull all those other pieces in together.
Yeah, for sure. And I want to mention that people can have this, and they can also have pelvic floor issues if they've never had a baby before. It doesn't matter how old you are. So I did want to point that out, because we often just say, postpartum, but the truth is that, males have pelvic health issues, females have pelvic health issues that have never had a child. So I just wanted to put that in our brain here.
And interestingly, the patient I was actually thinking about was the husband of the person who had the baby. And so It was like he'd been off for 2 years and not done any activity. And then all of a sudden he's trying to get back, and then things are screaming. So any kind of disruption can certainly do it too.
That's right. And then I wanted to say, in terms of like from a physical therapy standpoint and like a gait piece. So a lot of times that hip impingement that maybe has been there the entire time, or we just never looked at it, never caused any symptoms. So maybe it's happening if you're starting to overtrain, or maybe you're just starting to train for something more. Maybe the intensity is more. Maybe you're making a change in your life. But then if you've got any weakness in your hips, if you've got any weakness in your body that's causing your knee to kind of rotate in. So what I see a lot is we call it like femoral internal rotation. So where your knee that's pointing forward is rotating kind of in, or knee valgus where it's diving in. Those two things can also create some kind of hip pinching, but also something I see on gait analysis all the time is that arm swing. So like if somebody is swinging their arms with their body, like across their body rather than forward and back, what they're actually doing when their foot hits the ground is, I call it relative rotation of the lower extremity. So what happens is they're rotating their upper body over their leg, creating that pinching and internal rotation into the hip, which can cause pinching of the labrum and exacerbate any kind of symptoms in the groin. So from a gait analysis standpoint and looking like from a functional standpoint, I'm looking at what's happening with their rotation. How are they stabilizing their rotation? What's happening with their pelvis? Is it dropping? Is it going back? And can they maintain that leg in the proper way? And what's happening in their trunk and their arm swing? Because that is something that's actually missed a lot, is what's happening up above. We focus so much on the foot and the knee and the hip that a lot of times in runners, we don't even consider their upper body, their thoracic spine, their breathing, and their arm swing. And a lot of times with difficult cases or cases that don't seem to make sense, they don't even have to be difficult, or somebody who just has this pain they've never had before, we forget to look above. So I wanted to make sure we pointed that out, just because that's something I look at all the time and find constantly.
Love it. And I think I actually learned a lot of that stuff from you too, Kate, when I'd get stuck.
Yeah, that's what I mean. I've learned so much from both of you. I think that's the cool part, right? That's the interdisciplinary approach. So let's ask Kelsey.
Love it.
Okay.
I have a new connection out here in Colorado, and it's a pelvic floor PT. And what I didn't know is that she would have a lot of referrals for me. So what has kind of been the common thing that I didn't know is that when there is hormone suppression, specifically estrogen and progesterone, that can be directly correlated to weakening the muscles in the pelvic floor, which is fascinating.
Wait, I'm sorry. That is fascinating. I'm sorry. I just have to ask questions. And for either of you, and then I promise I'll let you go. But okay, so you said estrogen and progesterone suppression?
Correct.
Okay, so what about birth control and contraceptives?
That is an area, and Sarah, please jump in if you have different thoughts. I feel like we have more questions than answers. What I do know is that the estrogen and birth control is not the same as the active form of estrogen, estradiol, that is in our body. So I don't know how that impacts, birth control impacts the muscles in the pelvic floor.
Okay, I don't either. That's why I wanted to ask. Do you know?
Definitely, we have some homework. And I feel like even if we did homework, we wouldn't come up with the answer, because I feel like we have more questions than answers in these specific areas. And so if there's hormone suppression, then I would be really curious, and not saying that everything goes back to energy availability, but it does. So I would want to know more about their reproductive history in terms of the regularity of their cycles, or if they're on contraceptives, or if there was ever a period of time where they weren't getting a regular cycle. I'd want to do a diet recall to kind of understand what their demands were versus how are we meeting them through food and drinks. And then I would want to look at too their carbohydrate intake, because we know that female athletes specifically sometimes aren't, or not just female athletes, but more prevalent in female athletes, under consuming carbohydrates to support the level of training that they're doing, which can lead to not just progesterone and estrogen, but all kinds of hormone suppression. And then also, this is a huge one, especially because a few years ago when plant-based vegan diets really became popular, is a decrease in intake from saturated fats and cholesterol. And saturated fats and cholesterol are building blocks of hormones. So sometimes I get athletes where they might be consuming enough calories, maybe they're consuming enough carbohydrates, but based on the style of eating, they're just not getting enough saturated fats. And with saturated fat, I do want to say a little bit goes a long way, but when we avoid them like the plague, then I see a lot of my clients get symptomatic of that. And so that would be my curiosity, specifically if we're, really thinking that there is a pelvic floor component. And then there's things that Dr. Raiser and I were talking about before we started recording, that we can just make them a little bit more comfortable in terms of changing the amount of fiber in their diet, the roughage in their diet, so that they have easier digestion. But I would say my goal with that would be, it's almost like, I don't know if you ever use braces or orthotics, but no, we don't. Okay, we don't use braces and orthotics. Okay.
I try not to, but
okay, it's like using the lever then.
Yes.
It's a stepping stone to get you. Yes, it's a stepping stone to get, because eventually we do want them to eat fiber. So maybe altering their diet so they're a little bit more comfortable while they're dealing with this injury, if they are feeling that fullness and so forth. And so, Yeah, I think that a lot of it, I didn't realize that a pelvic floor PT would have so many referrals. So there's a connection there that I don't know if the evidence is showing yet, but definitely in the application to practice, we're seeing.
Could you give us a couple examples of saturated fats that you could add to things and also some fiber? Because I think that one of the things that happens is we're talking about these really big ideas
Yeah.
and it's good if we can give people like a few takeaways and things like, well, I don't know what saturated fat is, or I don't know what I should add to my diet for fiber.
Yeah, and I think even in this time frame, there's been so many generations of dieting, and my parents' generation was the low fat craze, and so people are terrified of fat. And then there's even how I learned it in school. There was healthy fats, and then there was bad fats. And it wasn't until I specialized in sports and specifically got more training in REDS that I started really, really harnessing the power of implementing these saturated fats into my clients' diet that oftentimes weren't eating enough. So, sources of saturated fats, full fat dairies, animal products, egg yolks. Ultimately, those are the ones that I would encourage athletes to focus on that other generations might have said, to eat the margarine and not the butter, or drink only the skim milk, or don't eat eggs. There's cholesterol in eggs, those kinds of things. And so, huge thing I'm seeing right now.
What about like olive oil and avocado and those kind of things?
Yes, unsaturated fats, those are unsaturated fats. So
Okay.
still really anti-inflammatory. That will help promote the HDL in the body and still very nutritious, still going to help you absorb fat-soluble vitamins. Very important. We want the bulk of our fats to be coming from those sources, but we don't want to entirely eliminate all saturated fats.
Great.
Yeah.
Thank you for that. I think
Yeah.
that's really
And
good.
then sources of fiber, there's different kinds of fiber. There's insoluble and soluble fiber. And so if we think about soluble fiber, that creates around bowel movements a gel-like coating. So it moves a little bit better. So I think about water and moving a little bit better. So those are sources like beans, legumes, greens, whole grains. And then there's a lot of sources with insoluble fiber too. Insoluble, I think of roughage with both, honestly, with like thinking about like the crunchy foods like salads, raw veggies, apples, stuff like that. And so they might want to, and same is true with a lot of GI conditions. Take a little breather from those or wait until they're a little bit more comfortable. It's like doing a heavy strength workout before a race. A heavy strength workout might be good for us, but there's a time and a place, right? And so same thing goes with fiber.
And one thing I was thinking about while you were saying that, that I think is really important, and this has especially come up in patients who have ulcerative colitis or Crohn's, and they're still running and very active, is that if your abdomen hurts, it is really hard to contract your abdominal muscles. So even thinking about being able to use your core if you have abdominal pain or bloating or constipation that's creating fullness, is certainly the GI piece is really important. And that definitely goes full circle to kind of the holistic approach to all of this. One other thing I wanted to reiterate too that I was thinking about that Kate had mentioned earlier was that definitely both males and females, I'm sending to pelvic floor for pelvic floor evaluations. So it's absolutely not just folks who are postpartum or perimenopausal, but we see it all the time. I have quite a few male athletes that I've sent for pelvic floor therapy that it's been very helpful for them, especially in the context of that labral tear or FAI. And I had one more point, but I'm going to let you guys keep going and I'll think of it in just a minute.
Now, I think this is actually a good point. Well, there's a couple things. One, I want to bring up our sponsor really quickly. So if you haven't heard, we have a new sponsor. So Lever Movement System is our sponsor, and we're so excited that they believe in us enough to sponsor us. This is a system that I use in my clinics a lot, and for various reasons, whether it could be performance or injury prevention. But I want to bring it up because with an athlete like this, so somebody that comes in where they're having a hard time running longer distances because of pain, and they're having a hard hard time. Maybe they're fatiguing, so their gait is starting to change and they're internally rotating, or they're swaying their upper body a lot with their run gait. I might have them use the lever. And, if you don't know, the lever goes on the treadmill, and it's a body weight support system. So it helps kind of offload some of your body weight. So you can actually do a little bit more without stressing your body out as much, which is really cool. So it is something that I would use maybe in a case like this. And I think, I'm super happy that they're sponsoring us, but also I use it all the time. So I really love it. And I think that the other thing we can do here is we've kind of defined what it looks like to maybe have an FAI with maybe some pelvic floor contribution to it, right? So we've kind of talked through that. And just something to say that active women, between 20 and 40 are usually the people that are kind of suffering from FAI. I mean, obviously it can come across the board, but it's definitely that age range we see it a lot more. And why don't we kind of wrap this up tonight with 3 things that we would like everybody to know from each discipline. So if you're somebody that comes in and you've got this anterior hip pain, groin pain, and you think that it might be either an FAI impingement symptom, or maybe it's a hip flexor, or you don't know if it's a bone stress injury, like what should they take away from this episode, from first Sara, then Kelsey, and then myself?
Yeah, so I'm going to give you takeaways that I didn't introduce previously. So I'm going to do something bad. You should never do this. But so I always tell people groin pain in a runner is a femoral neck stress fracture, so otherwise proven. So don't forget that piece. And then the other piece too with the pelvic floor is that a common comment I get from folks is, well, of course I have a little bit of stress incontinence. I had a baby. And I like to tell people that that's common, but not normal. And we can definitely address it. So don't forget to definitely want to have those conversations when we're in the clinic to address folks more holistically. And if it can help the running and help your hip pain, that'd be great as well. So.
Okay. Kelsey?
I would just say that, thinking about the different components of, I always reference the performance plate, which real quick is protein, carbohydrates, fat, fruits, and vegetables. So really doing a self-check of, am I consistently eating a performance plate and respecting all of the different components in a performance plate that it does for that athlete, and trying to take the years and years of diet culture out of it, because we want to perform like an athlete and we want the benefits of each of those components as an athlete. And so really removing all of the years of dieting that we've kind of been taught from that.
Great. And I think that what I would do is, or what I would like people to know is that if they've already seen, a physician, and we know that it's FAI or an impingement, I would say, let's look at your running form. Let's break that down a little bit. Let's see what's happening. Like, is it a functional issue that's creating the stress at that labrum, at that joint? So I would definitely look at the run gait and really break that down. I would also look simply at a single leg a squat. I mean, I think every single functional medicine doctor, orthopedic, PT, family medicine doctor knows that you have to look at the single leg squat, because you can tell a lot about what's happening in a single leg squat. We can see, what's their balance like? What's happening at your foot? Is your knee diving in? Is your femur turning in? Are you compensating by turning your body? So that's a really interesting thing to look at, even though it's commonplace. So, a lot of times people are like, oh, someone looked at my squat and it's bad. Well, yeah, who cares if it's a little bit bad, but if it's a lot, if you're seeing a lot there, that's when we really need to think about it. And then with something like this, it doesn't mean surgery necessarily, right? So an impingement is not a surgery issue. Labral tear, it may or may not be. And so I think a lot of people get scared when they hear FAI or they hear labrum, because they assume that maybe it's surgical. And so I just want to say that it doesn't mean that it is, and it possibly could be, just depending on the severity of the tear. But when it's an impingement, that's not what we're talking about. Cool. All right, guys. Well, this has been fun as always. So thank you. And for everybody out there, if you are interested in us talking about your case, or you have an interesting case that you're having a hard time with, whether it's like whether you're a clinician or you're a runner, you can send it to us and we will look at it and we will talk about it on the podcast and give you our opinions on what we would look at, what we're thinking in terms of the case. So you would just have to email it to us, and our email is runcasemiles@gmail.com. And of course, if you have any other questions for us, feel free to email us there as well, and we will answer them on another podcast. So thanks again, and have a good night.